So the typical image that comes to mind when we think of PTSD is a soldier back from war, right? But of course, many traumas can lead to PTSD. Sexual violence, family violence, surviving a serious accident, surviving a natural disaster, being forced to flee, being a civilian survivor of war. Those are just some of the things that can lead to PTSD. Now, rates of exposure to such major traumas are really high in the US population. So 6 out of 10 men, 5 out of 10 women will say that at some point in their life, they will survive a major trauma. And by age 45, most will have experienced one trauma, with a subset having experienced multiple. And my guess is that is probably the population you're treating right here in the county, that subset who trauma is part and parcel of their lives. Worldwide, the picture's worse. 70% of adults experience a major trauma at some point in their life. Over 30% experience 4 or more such events, right? So the key point to take home here is trauma exposure does not equal PTSD, right? You can survive a trauma. The vast majority of people will heal naturally. They won't need to see a mental health professional. But here's the thing, because the rates of exposure are so high to begin with, because it's such a common occurrence, even a small percentage translates to a lot of people, right? So low percentages are high numbers. And that's what we have to realize about PTSD. So where are we at in the United States? That means that at any given moment in time in the United States, there are 6 million active cases of PTSD that require treatment. Higher the dose of trauma exposure, the higher the odds of developing PTSD. That makes sense, right? So that's why there's higher rates of PTSD in our military personnel, where exposure to trauma is an occupational hazard. There's higher rates of PTSD in first responders, like police and firefighters. Higher rates of PTSD in low-income women. Higher rates of PTSD in youth who are raised in high-crime inner-city areas. So you want to be thinking, whenever you meet people from those populations, you really want to have your ear open to listen to trauma and how that might be impacting them. The type of trauma really matters too. So human-made traumas, there's something about the way humans are wired that when other humans intentionally hurt us, there's something about that that's more traumatizing, as opposed to, say, an act of God like a natural disaster. The mental health burden is huge. PTSD is really comorbid with depression, addiction, anxiety disorders. There's a higher risk of death by suicide. And then add to that the fact that a lot of them are hard to reach. Inherent to PTSD is the fact that people are avoidant. The last thing they want to talk about is their trauma. They're mistrustful. So guess what? They're not showing up for help. So collectively, you can see why it's a pressing public health concern and what the burden is in terms of mental health burden. So the article that I have pointed out in the slide, that was a really interesting study led by Charles Marmon, who's a pioneer in the field of PTSD. And basically, they followed Vietnam-era veterans over a long period of time. They did a longitudinal study. And they found that in 2015, the current prevalence of PTSD, so active PTSD in that population, for men it was 4.5%, for women it was 6.1%. So if you extrapolate that, 40 years after that war ended, there were still 250,000 veterans living with active symptoms of PTSD. So the take-home message is this: if we don't identify it quickly, if we don't treat it quickly, when it becomes chronic, when it becomes entrenched, it becomes this long disorder that really incapacitates and devastates people's lives. So as I'm sure you're all aware, PTSD has accrued many names over the centuries. Some of them emphasize the kind of physical impact, like shell shock. Others emphasize the psychological, like combat fatigue. So in essence, the human response to trauma, what we've found is that it's universal, okay? Regardless of the type of trauma, the response, they have much more similarities than they have differences. So even though, everyone has their unique presentation and we don't want to do a one-size-fits-all, the reality is people have more similarities when it comes to trauma than differences, and that's why we have this term PTSD to cover everything. Regardless of the cause of trauma, we use that phrase PTSD. It was recognized by the psychiatric establishment in 1980 in the DSM, and initially it's classified as an anxiety disorder. Right now, if you look in the DSM-5, it's got its own category, trauma and stress-related disorder, so it's distinctly different from an anxiety disorder. And in essence, what does it mean to have PTSD? You've survived a major traumatic event, and as a result, you have symptoms that fall into these categories. There's intrusive symptoms, there's avoidance, there's negative mood changes, and there's hypervigilance. And I'll talk about all those in the coming slides. Now, the key thing is your symptoms have had to have lasted for longer than a month. And they're so severe that they're disrupting your life, right? And you want to make sure there's no other psychiatric conditions that are complicating the picture. So that's the essence of kind of how we're diagnosing PTSD. Now, there's been a lot of complaints that PTSD is overdiagnosed, right? And part of the thrust behind me writing the book was I agree with that, right? So I think since 9/11, PTSD has become part and parcel of our modern vernacular. People use that phrase a lot, but they overuse it. I think it's misconstrued. I think it's sloppily invoked. So I agree. I think it is overdiagnosed, and that's not a good thing. But I also think it's simultaneously under-recognized. So I think there's thousands and thousands of people who have PTSD and are suffering, and they've never been diagnosed, and they're never going to get access to help. But I think it's also being overdiagnosed. So what can we do about that? So first of all, recognize the fact that it's normal to have symptoms of PTSD in the immediate aftermath of trauma. So symptoms similar to PTSD, I should say, that's normal. If that happened to any of us, if any of us survived a traumatic event, we'd have intrusive memories, we'd have nightmares, we'd feel shaken up, we'd be on edge, okay? But in the immediate aftermath, that's normal. Most people with time, they will heal. They don't need any type of medical intervention. We don't need to pathologize that period. Some people might even say that growth, they might even experience what we call post-traumatic growth, where they're stronger and wiser for the experience, and there's whole books written on that, right? So don't make this erroneous assumption that just because someone has those symptoms, they have PTSD. And like I said, trauma exposure does not equal PTSD. The other thing that happens a lot, which causes issues, is that people assume that the only mental health consequence of trauma exposure is PTSD, and that's not true, right? People can have all sorts of reactions to trauma. It can be a trigger for all sorts of things, depending on your unique vulnerability. Some people it might set off a period of depression. Some people it might trigger an episode of psychosis. So this is why it's really important we don't make those assumptions, because then I think that's how it gets overdiagnosed. Now, screening questionnaires and checklists have become increasingly available in the last several years, and they really increase the scientific precision with which we detect and diagnose PTSD. So PCL5 is one. Does anybody here use PCL5 in their practice? So I really recommend people look it up if you're not using it. It's easily available. Just Google PCL5 and it'll come up right there for you, and you can use it, and you don't need to get permission. It's in the public domain. And we use that in the VA. Everybody who comes sees their primary care doctor for their annual checkup visit, they get the PCL5. And I actually think that should be the case everywhere, regardless. It shouldn't just be a VA thing. I think it should be everywhere. Of course, these screens are designed to be biased toward false positives, right? We're going to capture a lot of people who don't have PTSD, but that's why we always need trained mental health professionals to really tease out who has PTSD and who does not have PTSD. So yeah, take home message, use screens. Otherwise you're going to miss it. If you don't specifically ask about trauma, you're going to miss it. I also want to make you aware of this term partial PTSD. How many people have heard of partial PTSD? Okay, so it's a thing, and I've got a reference slide. You can look up the paper if you're interested to know more. Millions of people, in addition to the 6 million who have PTSD, there's probably millions of more who have what we call partial PTSD. It's a sub-syndromal condition. They don't meet the textbook criteria, but they do have a history of trauma exposure, and they have some of the symptoms, right? And even though they don't meet the textbook criteria, nonetheless these people suffer, and they probably would benefit from professional assistance, and definitely as mental health professionals, I think incorporating that into your treatment plan is really key, otherwise they're not going to respond to what you're giving them, okay? So I'm going to shift now focus to the brain, because the last few decades have seen these stunning advances in the neuroscience of PTSD. And this world is always rapidly evolving, right? And there's always new technologies coming, and that's going to shift the landscape. But but I do want to summarize what we pretty much know to be true about the neurobiology of PTSD. So when we think of intrusive memories, which is that hallmark feature of PTSD, memories have become so integral to how we conceptualize PTSD that trauma scientists have actually started to call PTSD a disorder of memory. And for me personally, it's been really helpful to think of PTSD as a disorder of memory. It really helps me understand the symptoms that my patients are having. And I'll refer you all to the work of Chris Bruin, who's a psychologist out of London. I think he's the first person I read who's in his own words, he called it a disorder of memory. So think of it like that. So what do I mean by a disorder of memory? Well, there's two types of memory in PTSD, right? The first is that involuntary, intrusive reliving of the trauma. It's very vivid, it's very emotional. The images are so strong, they've been called indelible images, and they really derail a person's life in the day-to-day, okay? And the key point is the involuntary memories. The patient doesn't welcome them, they come to them, right? And they're triggered by environmental cues. The second is the voluntarily recalled trauma narrative, right? So if a patient says to you, you know, I was sexually abused as a child, or I survived a major car crash when I was a teenager. The difference with the second voluntarily recalled trauma narrative is that it tends to be disorganized, it tends to be vague, it tends to lack detail, right? And here, right in the differences between these two types of memory are it's the heart of the paradox that has been at the heart of a lot of controversy around PTSD, right? How can you have memories that are so vivid and so intrusive and so emotional, but at the same time you have a really vague recollection of what happened, right? So just be aware of these different types of memories, and it will help you understand how trauma stories present it the way that they do. I just want to point out the hippocampus. It's located in the temporal lobe, processes the storage and retrieval of our long-term memories. The hippocampus is smaller in people who have PTSD. And we don't know why. We don't know if it was small to begin with, and then they develop PTSD, and there's some correlation between the fact that it's smaller and why they develop PTSD, or is it the other way around? Was it perfectly normal, but then as a result of trauma exposure, their hippocampus grew smaller? But we do know that it is smaller, and that's just something that you should be aware of. Nightmares and flashbacks, those are, textbook symptoms of PTSD. I'm sure you meet people who complain of PTSD nightmares all the time. They are thoroughly disruptive, and they can go on for years. People often self-medicate because they're not sleeping. They get a really poor quality of life. Image rehearsal therapy, is anybody using that in their practice? Again, I encourage people to look that up. That is probably the best treatment we have that focuses on nightmares. And the reason I bring it up is even if people get evidence-based treatment for PTSD, a lot of times that nightmare symptom is still really stubborn. And image rehearsal therapy is the best treatment we have for addressing PTSD nightmares, and it doesn't have the side effects that medication has. So it's really something you want to be able to offer people. We use CBTI a lot in the VA just because a lot of PTSD sufferers have a lot of sleep issues, period. Even if it's not nightmares, they have insomnia or middle insomnia, or their quality of sleep is not good. So CBTI is something we routinely use too. I'm assuming people are using CBTI being for insomnia. Is that what people familiar with that? No? So again, I encourage people to look it up because it's another non-medication way of addressing sleep issues. Flashbacks, just briefly, these are involuntary, they're triggered by trauma cues, and they involve this intense, vivid reliving of the event in the present. So literally the person is reliving the past in the present. If ever you've seen someone have a flashback, it's very disturbing to watch. They are really, literally reenacting what they experienced at the time of the trauma. Really distressing for the survivor, but again, a hallmark feature of PTSD. Can we get the door, or just So let's talk about avoidance and denial, because I think it's something we don't talk about in PTSD. We avoid talking about it. Avoidance is a really core feature of PTSD. Oftentimes people develop two levels of avoidance. There's the emotional avoidance, where they avoid any kind of distressing memories, thoughts, or feelings that are related to the trauma. And then there's a behavioral avoidance. They avoid people, places, or activities that remind them of the trauma. So by doing this avoidance exercise, they manage to not get intrusive symptoms, maybe they'll avoid having flashbacks, but the result is they lead this really constricted life, right? Emotionally, they're shut down. They're not available to their loved ones. They're kind of distant. They really don't live life to the full. Now, the problem with avoidance is PTSD sufferers who have severe avoidance, they never come see people like us, right? So we never meet them. So avoidance is really like trying to catch a cloud in a jar. It's really elusive. Now, I do a lot of work in integrated care, and that's where I end up meeting these people who have lived 30, 40, 50 years of life with avoidance, but at some point it catches up with them. So, for example, if they hit a roadblock and they have a lot of medical problems, and it means they've got to come to the doctor a lot, or they're not in control, then guess what? All the PTSD symptoms start coming through. So my point is that I feel like it catches up with people. But we just don't tend to see these people. A lot of times I see the adult children of people who've had a parent who's lived with avoidance, because they complain about having a parent who wasn't fully available to them emotionally, who seemed shut down. So it does have casualties, it's just a lot more subtle and a lot more insidious. So one term that's come up in the literature is this notice that, an observation by neuroscientists, that people with PTSD, they tend to have over-general memory. So if you ask them about their upbringing, if you ask them about their life before they came to see you, they recall things with very few details. There's like a vagueness to it. And they describe this over-general memory because the theory is that people with PTSD, they avoid thorough search of their memory when they're asked to recall details of their past. And the way I equate it is to that experiment when people walk on hot coals. Like how do you make it across those hot coals without burning your feet? The trick is not to stay in one place too long, right? To walk really fast. And I think that's what PTSD sufferers do when they have to go back into their memories. They don't want to stay any one place for too long because they'll get burned. Okay? So that's another sign of overgeneral memory. So I wanted to mention the work of Dr. Rachel Yehuda. I'm sure you have all heard about her work with cortisol in PTSD and this phenomenon of epigenetics and generational trauma. So maybe if first I make the point that PTSD is a highly heritable condition. So even though in your mind you kind of think about it being linked to this external traumatic event, the reality is that a third of our response to trauma is probably determined by genetics, right? So how our unique brains are wired, the kind of response we mount to trauma, it's genetically determined. So again, back to the fact that all those people exposed to trauma, why do some develop PTSD? Why do some not? A third of it is genetic. So that's really important to be aware of. And then this field of epigenetics that we're probing using the human stress hormone cortisol, which is no doubt implicated in PTSD. I just don't think we have a really clear sense of how it's implicated. But epigenetics refers to how PTSD may possibly alter the way genes express themselves in a trauma survivor, and how such alterations can then be inherited by children on a cellular level and alter the child's neurons, brain molecules, neuroanatomy, and genes, okay? So these children of these traumatized offspring kind of carry these changes in their blood, even though these children themselves may never have been exposed to a traumatic event themselves. But then later on in their life, if these children are exposed to a traumatic event, they're going to respond with these changes that have already been made, right? So what's fascinating about epigenetics, and it's still early in the field, probably not ready for prime time, but what's fascinating is when you think of mass traumatization, when you think of torture, when you think of slavery, when you think of genocide, you have to think of the deep footprint that PTSD leaves, right? So in my mind now, whenever I meet somebody who comes from some background or some group that has been exposed to a lot of oppression or a lot of mass traumatization, that's always in the back of my mind, right? Even if the patient themselves may not have experienced trauma, it's always in the back of my mind, and I think you have to have that context to be able to evaluate people properly. So one of the most disruptive dimensions of PTSD are the outbursts, the recklessness, the hypervigilance, and the exaggerated startle reaction. So in the PTSD brain, the circuits that control activation and those that control relaxation, they are out of sync. All right? So someone with PTSD, they have a low threshold for sensing danger, and then they react accordingly. We know that adrenaline and noradrenaline is abnormally high in people who have PTSD, so their fight or flight response is not only easier to trigger, but the response is more pronounced too. The amygdala is implicated in PTSD. That is that almond-shaped set of neurons that lives in the temporal lobe. It regulates fear and pleasure. There's a study here that I've included in the slide. This is a landmark study by Scott Rausch and his colleagues at Harvard. This study helped identify that amygdala misfiring is key to PTSD. And then this other study by Lisa Shin and her colleagues at Tufts University, again, another landmark study that showed that the frontal lobe of people who have PTSD is more inactive, right? The frontal lobe, as we all know, is involved in planning and judgment and execution of our actions. So what does that mean? In the PTSD brain, the frontal lobe is more inactive than it should be, and so it's not able to exert control over this overly active amygdala, right? So the PTSD brain overreacts to threats of danger, and it can even imagine danger when it doesn't exist. All right, so that should help you interpret a lot of your patient's symptoms when it comes to PTSD. Definitely want to give a shout out to the moods of PTSD. I don't think that they get the attention they deserve. Anger, horror, and fear are probably obvious mood states. Shame and guilt are less recognized, but they are so key to surviving trauma. And again, if you don't know about it, you're not going to look for it because they're much more subtle emotions. But shame and guilt, in my experience, they're really integral to the life of the trauma survivor. Serotonin is also implicated in the lives of PTSD sufferers. It's meant to be lower for people who have PTSD, and the fact that it's lower is implicated in a lot of the symptoms like the anger, the irritability, the depression, and the aggression, which is also so closely associated with PTSD. So dissociation is worthy of mention. How many people are familiar that there is now a dissociative subtype of PTSD? In the DSM-5, if you look at PTSD now, there's an official dissociative subtype. That wasn't there in the 2000 DSM. So again, that's why I think it's really important people be aware. You know, derealization is that feeling that the world is not real. The world around you is not real. Depersonalization is that feeling that you don't feel real, right? It's normal for human beings to experience these things once in a while. I don't know if you've ever experienced it when you're sleep deprived, when you're really stressed, when people are bereaved. It's common to have these experiences. But in the dissociative subtype of PTSD, they occur really frequently, every day. They dominate the day-to-day life of the individual, and they're totally disruptive, right? And there's functional brain imaging studies that show a distinctly different pattern of brain activity for people who have the dissociative subtype. So it's kind of got its own imprint, and that's why I think it's important to be aware. And as the slide said, 15 to 30% of PTSD sufferers have the dissociative subtype. So rather than fight or flee when faced with trauma, these patients, they tend to freeze, or they kind of dissolve in this process that neuroscientists have called emotional overmodulation, okay? So that's what's going on in their brains. Now there is this theory that I think is fascinating. It's called betrayal trauma theory. A lot of times when I see the dissociative subtype, it's been in people who've got really severe child abuse histories, right? And the theory goes that dissociating gives victims who are dependent on these abusive caregivers for food, water, clothing, and shelter, right? Imagine a child who's being horrifically abused by primary caregivers. They have to find a way to maintain their attachments with the caregivers, right? For their survival, they're just kids. Dissociating gives them an out, right? If they can't remember what happened, if they dissociate from it, they can maintain those attachments necessary for their physical survival until they become grown-ups. Now, that process of dissociation, it interferes with the coding, the storage, the retrieval of memories. So a lot of times for these patients, these trauma memories, they're kept out of their conscious awareness. So if you ask them if you've been traumatized, they may say no. And if, they might not volunteer an abuse history, okay? Now, even though this mechanism of dissociation might have worked for them when they were a child, it might have been a way of coping and surviving as a child, unfortunately, down the road, it's actually a much more severe form of PTSD. So again, just really important to be on the lookout for that. Again, what has happened in the last 20 years is we know so much more about the consequences of trauma exposure and PTSD on one's physical health and the relationship between trauma and the body, right? And this exposure has consequences across the lifespan from childhood to older age. So the first take-home point is there's an unequivocal link between PTSD and poor physical health. So when you think of cancer, when you think of obesity, when you think of heart disease, when you think of strokes, it's really important to treat PTSD because that can contribute to all of those disease processes, right? And there's three main ways how it contributes. First of all, is literally biological. PTSD disrupts hormone secretion, it disrupts neurochemistry, it disrupts immune functioning, and this all contributes to disease in the body because it leads to diseased cells and diseased organs. Psychologically, depression and PTSD often go hand in hand, and I think there's already a pretty robust literature showing how depression contributes to physical disease. So when the two of them are present together, which is very, very common, the kind of combined toll is pretty considerable. And then there's the behavioral arm, right? So we know that people who have PTSD, much more likely to abuse alcohol, much more likely to abuse cigarettes, food, sex, you name it, they're much more likely to abuse it, and they're less likely to take preventive measures to proactively support their health. So less likely to exercise regularly, less likely to eat healthy, less likely to practice safe sex. And then if they're given medical advice, we know they're less likely to follow it. So, you know, if the doctor says, hey, your blood pressure's up, you need to take a blood pressure medication, they're more likely to be known to do it. So you can see the combination contributes to a lot of disease. This study that I've cited in this slide here speaks to overall mortality rates too. So in this study, they followed a cohort of Vietnam-era veterans over time, and what they found was the veterans who had PTSD, their rates of death increased 2 to 3 times over the study period, even after they controlled for race, level of education, income, and marital status. So literally your odds of dying are higher if you have PTSD. I really want to give a specific mention for heart disease. There could literally be a whole lecture on PTSD and heart disease because there's that much great data that's come out in the last 10 years. And not just kind of correlation data, causation data. To the point that last year in the Lancet there was a publication that basically said PTSD is an independent risk factor for heart disease, right? So what does that mean? The same way a physician would encourage a healthy lifestyle by making sure your cholesterol levels are normal, making sure your blood pressure levels are normal. We need to address PTSD too. It's an independent risk factor, and if we don't address it, we're not doing a good job. So that's where, as mental health professionals, I think that's where we play a key role. Addiction has been referred to as the tip of the PTSD addiction iceberg. Up to 60% of addicted persons also have PTSD. It's really easy to see why people would self-medicate, right? Why people with PTSD would self-medicate. A lot of times using alcohol or drugs and kind of seeking that altered state really takes you away from the anxiety and the nightmares and the kind of distressing symptoms of PTSD. Unfortunately, what I witness is that too often this coping strategy just becomes morphs into an addiction, right? And then it just becomes really complicated. And the PTSD becomes harder to treat. So I'm always on the lookout for signs of addiction or abuse in my patients with PTSD. I just think they're very vulnerable. What you should know about is this troubling relationship between PTSD, chronic pain, and opioid addiction. So up to 35% of chronic pain patients also have PTSD. There's actually some literature that suggests, it's pretty controversial, but that fibromyalgia and PTSD are actually the same thing. There's such an overlap, right? So What do we know? This study that I pointed out, this JAMA study that was published, it was like a big data study, and it offered this really bird's eye view of what's going on in people who have PTSD and chronic pain and who are prescribed opioid pain prescription pills, right? They compared that group to people who just have chronic pain and are prescribed opioid prescriptions for their pain. And what they found is in that former group, they were much more likely to have adverse consequences like an unintentional overdose, or an act of self-harm using the pain pills, or a fall whilst they were taking the pain pills, when compared to the group who just had chronic pain and no PTSD. So what are we saying? I think when people use pain pills to numb emotional pain or psychological pain, instead of getting treatment for their psychological trauma, that can be really dangerous. So again, to be on the lookout for that. So a little bit about childhood and older age. Adverse childhood experiences, the ACE studies, have folks heard about those? Yeah? Okay, good, excellent. So as you know, that was a collaboration between Kaiser and CDC, and they looked at the relationship between adverse childhood experiences, which is typically things like neglect and emotional abuse or witnessing violence in the home, and what happened to health outcomes. And as you all know, in essence, what they have summarized is that adverse childhood experiences are the main determinant of health and social well-being in our nation, right? Now, I know I'm preaching to the choir, I know you all know this, you've probably known this for much of your life, but I think what is great about the ACE studies is the rigor, the depth, the scale of those studies really makes that statement unequivocal. There's very few people who can argue with that now. So that's ACE, that's adversity in childhood. What about trauma in childhood? PTSD happens in children, right? Trauma, when I talk about trauma, I'm talking about more potent, life-threatening trauma with a big T, you know. Kids who have PTSD, there's changes on their brain scans the way there are in adults who have PTSD. Children are uniquely vulnerable. You know, this notion that children were resilient just by being children is not true. If children experience really severe trauma at a younger age, it can have a really devastating impact. PTSD rates in children skyrocket when when their community is ravaged by trauma. So you think post 9/11 or you think post hurricane, kids are really susceptible. And how the parents and the communities cope determines a lot of how children will cope. So the resilience of the community is really vital for the kids' mental health. Obviously, how PTSD manifests is going to vary in kids depending on their developmental stage. So if you take a 5-year-old kid who does not know or understand that death is irreversible, they're going to respond to trauma very differently than, say, an adolescent who's almost an adult and who understands the existential threat that a trauma could represent. So depending on the age and the developmental stage, it's going to have a different picture. But the key thing is this: when a child develops PTSD, it's going to have a negative impact on the way they learn, the way they play, the way they socialize. So again, detecting it and treating it is really key. And older adults, definitely in the last couple of decades, as people have been living to a longer age, there's been this great opportunity to see how trauma gets processed over the years. We know a lot more now about what PTSD looks like in older adults. There's this retirement phenomenon that we see a lot in clinical practice and it's been written about, that in essence a lot of older people, they've been workaholics their whole life, right? And that's how they deal with the trauma. It's a form of addiction. They just work, and guess what? When they retire, bang, the symptoms come to the forefront because they no longer have that work to hide behind. Got to bear in mind too, the aging brain is not as resilient, it's not as quick, it's not as versatile as a younger brain, so that in itself can put people, make people vulnerable, that the ways they might have coped with symptoms in the past, those coping strategies are no longer working, so a lot of times PTSD can present for the first time in older age. What's fascinating for me is how older adults tend to, they might not see something that I might think is traumatic, they might not view it as a trauma, depending on the generation they were raised in, right? So a lot of times I'll see people in their, I'll see veterans who are in their like 70s, 80s, sometimes even 90s, and they had horrific sexual trauma histories, which they experienced either as children or as youth or in their 20s, which they literally just locked up and threw away the keys. They just didn't even think about it. They weren't living in a time where they had a voice or a platform to say what they had experienced. And they never really thought about it, never spoke about it, never told anyone about it. And then over the last couple of years with the Me Too movement and with this real change in the zeitgeist of what people are disclosing, bang, their symptoms are like full force, right? Now that's the only thing they can think about. So cultural context, social context, think about that when you're dealing with older adults, and definitely older adults from different cultural communities too, because I think it can be even more taboo in certain communities to talk about trauma. So, interesting relationship, this suggestion that having PTSD can increase your odds of developing dementia. Again, we're really at the stage of correlation. I don't think we have enough evidence to say that it's causative, but we should be aware of that. What we do know is that older adults, for sure, who have PTSD, they tend to perform poorer on memory tests. So when it comes to processing information, new learning, executive function, they do not do as well. So again, this notion of PTSD as a memory disorder, this is coming into play when you look at neuropsychological testing. There's this condition known as late onset stress symptomatology. Has anybody heard about this? So again, I would look it up if you get a chance. Something I only became aware of probably the last couple of years. So it's not PTSD, it's probably a cousin of PTSD. And if any of you regularly see older adults, basically what happens is an older adult, they become obsessed with something that happened in their past. It could be something from 30 years ago, 40 years ago. It was something just really upsetting to them emotionally, possibly even traumatizing. And they become obsessed with it. And that's all they are thinking about. They're not eating, they're not sleeping. That's all they're thinking about. And like I said, it's not PTSD, it doesn't have the hallmark features of PTSD, but it's kind of like a close cousin. And I think the way we're conceptualizing it right now is that it's not necessarily a pathology. It might be a mechanism by way of people can put things right or make peace with the situation before it's too late. It might be the brain's natural way of helping people resolve some issues, obviously before they pass away. So just to put it on your radar, the way I came to know about these cases was family members were bringing in patients who were basically spending days just preoccupied with these events, literally from 50 years ago. So again, just be on the lookout for late onset stress symptomatology, otherwise known as loss. Quality of life, PTSD is really intertwined with gender, race, poverty. It destroys quality of life and human relationships. People with PTSD can be a risk of harming themselves or harming others. So, just to have a sense of the kind of impact that it has. Complex PTSD. I'm sure people have heard about complex PTSD. It's a niche diagnosis. It was put forward by the Harvard psychiatrist Judith Herman, who was a pioneer in the field of psychiatry. She wrote a book called Trauma and Recovery. I think that book is 20, 30 years old. Really eye-opening book. I read it when I was a resident. Really was helpful to me during my career in finding ways to empathize with patients who I think otherwise would have been diagnosed as having a custody personality disorder. But actually what you're witnessing is people who have been chronically traumatized. So if you look at survivors of intimate partner violence, family violence, like prisoners of war, or people who had horrific child abuse histories, who are chronically traumatized. So, not just this one trauma where their life was fine and then they had a trauma. People who've been exposed to chronic trauma. It's normal for them to have denial, emotional numbing, use dissociation, and to have issues with emotional regulation, where literally they'll be raging 1 second and then have regret the other second. And this really plays out in their interactions with caregivers and with medical professionals. It used to be, a lot of times, if I would have seen those patients, I would have been like, oh, they have custody personality disorder, because your reaction that you have to those patients is often very negative, your own countertransference is often very negative. But complex PTSD really helped me understand that what's being reenacted here is their experience of the world, where they're used to being traumatized, where they are used to people letting them down. So again, I think it's a helpful thing to think about when you're dealing with people who have pretty severe trauma histories. Intimate partner violence, definitely want to mention that it's a public health issue, not only in the United States, around the world, hundreds of millions of women. Rape, battery, other forms of IPV is just a daily fact of life. Of course, IPV leads to PTSD along with other mental health issues and along with a lot of physical health issues, but the rates are really high. So it can be as high as 64% PTSD rates in IPV survivors of severe IPV. So I just want to put that out there. In my mind, IPV is the best example of how one's social reality can really change your biology, right? So someone who's been in a chronically traumatizing relationship with a severe IPV, oftentimes biologically they are so impacted that literally, unless they get professional mental health attention, they just can't make a decision about their future. You know, it's not as simple as extracting them from that relationship and everything will be fine. They literally need professional mental health attention before they can be back to normal. So, are people who have PTSD more prone to violence? Violence rates in the general population are about 2%. If you look at studies with people with PTSD, that rate jumps up to 8%. So at first glance, you might think, yes, people with PTSD are more prone to violence. But actually, if you do the deep dive in that data, if you control for age, if you control for substance abuse, if you control for other psychiatric disorders, then the rate comes right down pretty much to baseline. So even though having PTSD is associated with a slightly increased risk of violence, the reality is that the overwhelming majority of people with PTSD, they've never been violent. Conversely, risk of death by suicide is very real, and it's much higher in people who have PTSD. And where I get a little nervous is there's a higher risk profile within PTSD sufferers, so where intrusion, anger, irritability, when they're more salient features, when they're more prominent, I get a little bit nervous. Where survivor guilt is an issue, where shame is an issue, you know, it's called shame, this soul-eating emotion, right? I get more worried about suicide in my patients. Comorbid traumatic brain injury, that's another way people are high risk of suicide. So if you think about it, let's say somebody survived being shot at, or they survived an explosion or a severe car accident where their brain was literally injured and they have a traumatic brain injury, and then they also have PTSD as a result of that trauma. Coping with the symptoms of PTSD when your brain isn't functioning properly is just really, really difficult. So they're at higher risk of death by suicide as well. The best intervention for preventing suicide is access to high quality mental health care. And the problem is, like I said, oftentimes people who live with PTSD are just really hard to reach. So we never see them, right? So that's the problem. So re-engineering mental health care to make it more accessible, more acceptable, more available for sufferers, I think is key. And that's kind of what a lot of my own research focuses on. I can't talk about it today, we don't have time, but I think that is really the next frontier. So a note on gender. Women are more likely they're less likely to be exposed to trauma, but they are 2 to 3 times more likely to have PTSD, right? So why is that? Part of that might be because of hormonal differences, that might explain the difference. But I think most of it comes down to the types of traumas that women uniquely face. Right? So women are more likely to be the victims of sexual assault, women are more likely to be the victims of intimate partner violence, and there's something about these traumas that are potently traumatizing. Rape is actually the trauma most likely to lead to PTSD, even more than combat trauma. So I think crimes like rape that have historically carried a lot of stigma, that have forced survivors into silence, or even if the survivor speaks up, a lot of times they'll face these what we call secondary injuries, where they're subtly blamed or they're shamed for coming forward. That in itself worsens the outcome and it contributes to PTSD. There's something about either the way women are wired or the way that they are socialized. Social support really is powerful in helping women heal from trauma. And conversely, when they're denied that social support, they're much more likely to develop PTSD. So just bear in mind that there's probably many reasons to explain the gender differences in PTSD. I do want to give a shout out to birth trauma. Is that anybody's heard anything about birth trauma? So, okay, great. So if you Google the term birth trauma, it's really interesting. So birth trauma is not a thing in the DSM. It's not a formally recognized thing. But if you Google the term birth trauma, there are so many self-help groups, advocacy groups, patient right groups, and also now there is a literature on birth trauma. And in essence, what happens in birth trauma is women are severely troubled by a lack of expectation in how they wanted their birth to go and how it actually went. And there was something about that experience that was demeaning, and typically the context is when women are giving birth in big medical hospitals as part of the kind of medical industrial complex where they feel demeaned, or they feel they don't have a voice, or they're not being heard. And it's a big issue, right? It might not meet the criteria of what we would consider trauma, but it is an issue, and I just want to put it out there. I think we're learning more about it. Postpartum PTSD, that definitely is an issue. So if a woman is giving birth and her life is threatened, during the birth, or her baby's life is threatened, she has a severe postpartum hemorrhage, or something happens that is unexpected or traumatic, she can definitely develop postpartum PTSD. And if you actually look at the rates of postpartum PTSD, it's not that different to postpartum depression. But yeah, I think we know a lot more about postpartum depression than we know about postpartum PTSD. And I think we're a lot better at screening for postpartum depression, but I don't think we ask about postpartum PTSD. But try it. With your patients who recently had babies, talk to them. How did it go? How was the birth? Did you have complications? Did things go as expected? Just ask them, check in. Don't